think the green is pretty straightforward.
Is it on? Yeah? Good afternoon, everyone. My name is Sharon Tamir, and I'm delighted to open the session of Advance in Diagnostic and Prognostic Biomarkers. I think that since, given we're all in this room, I believe that there is no need to elaborate, and we all acknowledge the importance of biomarkers as a key component in drug development and treatment. As we all know, there are multiple emerging biomarkers for either direct, surrogate, prognostic, and diagnostic. And we're very fortunate to have two speakers today. Unfortunately, our first speaker just noticed us that she's sick. I thought that flu season is over when spring is here, but I guess I was wrong, and she cannot be here with us. But we're fortunate to have the two other speakers. And I'd like to present the first one, Dr. Boaz Levy from University of Massachusetts. Dr. Levy has an interest in the link between cognitive impairment and function adjustment. He started his training in neuropsychology in graduate school in USC in the Alzheimer's Disease Research Center. He then pursued postdoctoral training at McLean Hospital with geriatrics specialty. In recent years, he, as faculty at the University of Massachusetts, he focused on advancing the application of cognitive markers in the primary care setting and memory clinical as a standard of care. So without further ado, I'd like to invite Dr. Levy to talk about cognitive markers of dementia in primary care.
Thank you very much, Sharon, for the kind introduction, and thank you for the opportunity to share some of my work here this afternoon. So a few years ago, we started this work with a conceptual paper that examined the theoretical, methodological, and practical aspects of developing a cognitive marker for primary care. And in it, we stress how vital the integration between these two constructs is for preventing dementia. It has to do with the idea that for public health purposes, cognitive marker is inextricable from the context of primary care. And I will elaborate on this central point several times as I go along. So starting with a few words on cognitive marking independent of primary care, the raison d'être, if you will, why we need it. Clearly, the somatic changes in the brain precede the cognitive decline, so the question is, do we really need to develop, to supplement biological with cognitive markers to forecast dementia? And the reason for that is twofold. The practical challenge is prime and central. We have a scalability problem. Forecasting dementia is a formidable task under any circumstances, but it is compounded 1,000-fold when it is scaled up to epidemiological proportions, because the brain is walled up in a number of very effective layers of protection, so obtaining data directly from the brain is very difficult indeed. Even just taking a diagnostic picture of the brain is quite an ordeal. So most biological methods are in some way expensive, invasive, and labor-intensive for community-wide screenings. And stated simply, we cannot put America through the scanner every year. There's other advancements, of course, but we need more efficient proxies to marking, and plasma and retinal methods offer improvements in this regard, and there's good work of other people. Yet when it comes to procedural efficiency, you can't beat cognitive assessment. So even though it comes second in the to biology in a timeline of signs and symptoms, it still fits perfectly with community-wide preventive effort. The second reason is more conceptual in nature. Cognitive markers target the most fundamental aspect of dementia in the clinical sense, namely the impairment in mental abilities and psychosocial functioning. So dementia has a biological underpinning, but clinically speaking, it is inherently psychological or behavioral in nature. This is why it's in the DSM. And biological data help with diagnostic accuracy, but diagnosis of dementia is never based on biological factors alone. So to an extent or to a degree, from a public health perspective, biological marking is largely valuable to the degree that it can predict or explain the cognitive impairment, which is responsible for the suffering, disability, and cost associated with dementia. So even though the biological changes occur first, both markers are needed. The preclinical pace of cognitive change matters a great deal. So moving on to primary care, anything we develop to predict dementia for the population at large will ultimately be deployed by primary care simply because primary care constitutes the point of contact between medicine and the general public. If primary care won't do it, it will not happen. So we are not truly free to do things our way. We have to do things from the perspective of primary care, and there are major implications to that, which I will describe shortly. But first, the general strategy is to incorporate a cognitive assessment to the annual physical exam or wellness visit in the pre-morbid phase of dementia. Then, observe the slope of cognitive aging over time and detect departure from cognitive health as early as possible. And to do this as a policy or as a standard of care, we need to establish a solid, healthy baseline for later comparisons starting in midlife, as opposed to screening the elderly for cognitive impairment, which is the current practice. Quantifying the population slopes of cognitive decline can answer the questions of how fast patients are aging, relative to themselves and the population at large. When designing a marker for this purpose, we need to take into account the current economic structure and practical realities of primary care. Many practices now operate under the pressure of fee-for-service volume, which imposes enormous constraints on accommodating new screens or any procedure. In many instances, the physical exam is now limited to about 15 minutes, so there is very little room for adding a cognitive screen. So this means that we need to develop a procedure that is almost weightless, that is self-administered and takes about 2 minutes to complete, and in addition, readily integrates into the routine of health assessment and auto-generates easy-to-interpret results, that requires no special training and offers multi-versions to avoid the bias of training effects upon repeated measurements. And of note, the level of efficiency required from this procedure here goes against the traditional training of clinical neuropsychology, which with its 8-hour-long batteries and its 8-hour-long analytic work that follows that. So creating a 2-minute screen is easy to do. The hard part is to make it clinically useful. So a question arises. What can we do in 2 minutes or less? So right now, the minicog is about what we have available, remembering 3 words and drawing a clock. But failing the minimal challenge of the minicog is already too late. It cannot be used for early detection or as a marker or a preclinical marker. This introduces the principle of assessing cognitive limits rather than assessing predetermined notions of deficits or impairment. Most dementia screens do the latter. To understand departure from healthy aging, we need to measure its slope. We need to understand what healthy aging is. It can only be observed from the maximal point, the cognitive limit, which declines every year. There will be no difference in the minicog performance, MMSE or MoCA, if you will, between the age of 45 and 55, although people are clearly aging cognitively. A low ceiling of the test creates a masking problem. Ordinary screens detect the problem too late. A test that is both sensitive to healthy aging as well as abnormal decline will assess the cognitive limits of patients. So efficiency is one central aspect, and assessing cognitive limit is another, and yet a third critical piece has to do with cognitive domains. What the test actually measures. What domains are most sensitive to both healthy and abnormal aging? So here's one answer. Processing speed and cognitive control here in the way of executive switching, and to illustrate, the Trails Making Test B requires people to shift back and forth between 2 ascending series of numbers and letters. So it's drawing a line between 1 and A, then the 2, B, 3, C, 4, D, and so on as fast as possible. And this test has been with us from the inception of clinical neuropsychology for about 75 years now. And it continues to be embedded in most contemporary batteries today. And here's the beauty about how this test is working for marking purposes. We are looking for a slope that becomes much steeper in healthy people at around the age of 60, which tends to align well with the premorbid phase of dementia in many cases. So the sensitivity to healthy aging may flag problems earlier on. And the notion is that tasks that become more difficult with age become much more taxing for people who deteriorate faster. So we will see the shift in slope in an earlier age if there are problems. Such a test can detect precipitous decline, which may not be apparent in the natural post-retirement environment due to its lower cognitive and functional demand. On this basis, we created an analog to the Trails Making Test B. And here, subjects are asked to alternate between even and odd numbers in ascending orders as fast as possible. So starting with the smallest even number, switching to the smallest odd number, and then go on to the next smallest even number, next smallest odd number, and so on. And this is under time pressure. And in an analysis of convergent validity between brainometric and, say, the Montreal Cognitive Assessment, which is one of the most widely used today, a k-mean clustering of brainometric data assigned participants to groups that correspond to healthy, mildly impaired, and moderately impaired ranges on MoCA score. However, a machine learning classification of participants according to MoCA clinical cutoff score indicated that brainometric is not sensitive enough to mild cognitive impairment range of MoCA scores, which again emphasizes the difficult trade-off between procedural efficiency and clinical utility. It's about what can you do in 2 minutes or less. Brainometric does, however, demonstrate the age sensitivity it was designed to achieve and to illustrate that the top MoCA score of 30, which is the ceiling of MoCA, age accounts for 26% of the variance in completion time of the even-odd switching task. So you take the top performers, the maximum score you get on a cognitive screen, and age correlates with that very well, and it would not in the MoCA. And this is the characteristic that we're looking for. To improve the sensitivity of brainometric, we have now added a memory component to the test and we shortened the even-odd tasks that I've demonstrated before. And there's a demo, but I don't have a way of demonstrating it from here. So I'm going to go to the back of the room with a microphone and try to kind of operate it from there. Okay, so this starts with the balloon test. Oh, you can't see it. Okay, so we lost 25 seconds. I was about to demonstrate in under 2 minutes, but we'll keep that in the count. So we start with a motor speed, which deteriorates with time, but this is important in terms of accounting for the platform on which we're operating, because there's many and they can vary. The balloon popping measures reaction time to something that's not cognitive in nature. It's just a simple motor reaction time, and we take the median reaction time of that and subsequently subtract it from later reaction times. And here we're asking people to remember 3 two-digit numbers. So we got 51, 68, 73. I'm going to try to remember that. And we have 15-second exposure. And here's the even-odd task. So we have the instructions for that. And then we're looking for the lowest, the smallest even, smallest odd, next smallest even, next smallest odd. Now make a mistake on purpose here. So it's going to tell me where to go. Smallest even, smallest odd, smallest even, smallest odd. Now I don't remember the numbers. Can you help me? 51. 78. 73. And 68. Here we have 68, 73, and we had 57, what was it? 51. Okay, so if you take out the 25-second and the pressure conditions, I think we're almost there. Can you get me back? Okay, now the computer, the wonderful thing about the computer as opposed to a physician or a technician is that they can record a lot of different things. So we can record every reaction time, how long it takes to read the instructions. We can, out of that little exercise, we can extract at least 70 different numeric values and combinations of ratios. The list goes on and on. I won't bore you with the details. But what's helpful here is some of the new advances in machine learning statistics help to understand pattern recognition and being able to subtract, say, last year's performance from this year's performance in each element. And then you don't have one slope, you have 70 different slopes. And so it becomes a multivariate type prediction. But overall, in that multi-slope environment, the hope is that we'll be able to combine that with the biological data that primary care will collect and has already in its records, or any biological markings that it will collect on an annual basis, and that's the hope. We have a multidisciplinary team. I'm a clinical neuropsychologist, and we have geriatric medicine, geriatric psychiatry, primary care, and machine learning. And that's it. So the take-home message is efficiency is paramount. Testing cognitive limits is very important. And that's about it. Oh yeah, questions?
So are you recommending that these be done annually in their primary care office? And then what do they do with the results? Or who assesses whether they're going off track or not? Because primary care physicians won't be able to do that.
That's yeah. That is the central question and the pushback that we get on this work. So the answer to the first question is yes. We would like this to be done on an annual basis starting age 45, because we need to understand the preclinical slope when people are healthy. We need a way when something changes, we need to compare it to something that we've established before. And I think 45 or 50 would give us a good 10 or 15 years before something changes for comparison. That is so important because cognitive testing is very, very sensitive to noise. How much sleep you had last night, how many drinks you had last night, it all affects. So figuring out what is circumstantial or local effect versus what counts as a real change is a real challenge. And so this is why more data allows us to get essentially more statistical power. So yes. And then I think we need to develop an algorithm that will tell the physician, this person, there's reason or probabilistic reason to send this person for further assessment. So it's not diagnostic. It's just a flag saying, we need a clinician now in the room doing a real assessment. And hopefully that you will not be making this, this determination based on cognitive data alone. We hope to combine the biological with the cognitive, and then it's going to be, I think, in the AI realm. So it's not going to be interpreted by, because if you think about it, we're trying to capture something that's preclinical. So if you ask the person how you're doing, they might say, well, for the most part, good, especially if they're retired and nothing's really challenging. But there's another aspect, and I didn't talk about it here, of subjective memory complaints, and that actually tends to, sometimes if you don't ask, they don't tell you. And sometimes if you have a flag and then you ask and there's another flag of subjective complaint, then that could add to predictability. The third question you asked is about what to do with it. That's a big pushback, is that we don't have a pill to give them. There's a lot of lifestyle changes that have been proving promising. There's the finger studies. There's Dale Bresnan, work in California that's been gaining attention. I think we can change the trajectory, even though it's never been fully acknowledged by medicine quite yet. But at least I believe it.
Should we be doing this from a different direction, not involving primary care, doing somehow online, or getting people to sign up this way? And then my other question is, would it be biased to the people who sign up?
Yeah. I think we toyed with that idea. It's much easier to go directly to the community than to deal with medicine or medical institutions. Much easier. But in the end, if you want to standardize things, and in the end, if you want the guiding hand to be of medical nature, you kind of there's no way around it. So I let that idea go. Even though it was very appealing, practically speaking, but it's. It's more of a referral situation, right? Yeah. Thank you.
I had a similar experience trying to implement things like that, not as computer-based as these are, in Costa Rica in a similar study, and I just want to emphasize how daunting it is for primary care to be given another 10 minutes worth of work between patients. They really balked at it, even though it was seemingly simple to us. It's a time factor. But one way that it could be taken away, you have to make it appealing to the primary care doctor, because it's going to take time away from spending time looking at the testing, is engage a company to actually track this data on a cloud. So the data is acquired almost automatically when they go to the office, and then track it on the cloud, and it's processed offline so that you can start looking at the slopes, provide the doctor with an aggregate report of these are all the patients that you've sent us, and then these are the ones who need attention, and then you list them by priority, and then give them a mechanism to, if they're flagged because they're beyond this slope,
Right.
This is the psychologist who can then do the proper testing to pass the screening. And there are companies that can figure out ways of making money on that if you do it diligently and you're providing the foundation for it, which is the data that you're showing.
Well, thank you. I think that's precisely what we're aiming for. The idea is to have the physician deal with absolutely nothing in addition to what they're dealing with, because I've come to that realization very quickly when you have a group of primary care physicians in the room and you start by asking, can I? They say no. But you don't blame them, because something in their system is truly overextended in the ways that you're describing. So very much in the very way that you've described, we're trying to simply have it run almost like a vital sign, something that the physician doesn't do, something that's self-administered, and something that will kind of run through the algorithms and appear as a red flag for the physician to send for referral, very much like a blood test that's saying, you know, your vitamin D is out of the healthy range, why don't you take a supplement? But here will be, there's sufficient reason, you know, to, you know, follow up with another assessment, a memory clinic or something like that. That's exactly the procedure that we're kind of aiming at. Yes. Yes, and it has a very critical. The deployment in primary care will enlighten us in so many ways, because if you think about it, if you want to collect data over 30 years and look at conversions from health to dementia on epidemiological scale, in a research capacity, that's the labor and the dollar amount of that is unimaginable. But if the data is being collected anyway in a standardized form over a very diverse representative community, you can begin to slice it by demographics, et cetera, and to get more homogeneous comparisons, et cetera. So if you're a physician, you have this many years of education, et cetera, you don't want to be compared to someone who's don't have the same cognitive reserves, because you can still look good relative to someone who's not as privileged as you were. And so we would like to kind of have a good sensitive comparisons as well.
Maybe it goes without saying, but the road to hell is paved with good intentions sometimes. And one of the worrisome things about screening things, if you look at the history of screening, as I understand it, when I was a medical student, no one measured bone densities because there was no Fosamax. When Fosamax became available, suddenly measuring bone density as a primary care doctor became part of a standard every 5 or 10 year, whatever the duration is, assessment. And similarly, now we measure a lot of things where there's become increasing controversy about whether it's worth finding out. For example, PSAs, some of the breast cancer mammography screening. Some of these tests have started to lead to a worry that we're doing things that probably are not warranted, causing anxiety, et cetera. So I think, the thing that I get out of those two stories is if there were something to offer, suddenly primary care doctors would be very motivated to spend 2 minutes doing this test. But until there's something to offer, it's just a hassle. At the same time, if you don't have any kind of specificity, then you have a problem. The only other point I wanted to make is just looking at you do the computer test. It reminded me of the old thing in the abstract submission form for the Society for Neuroscience. Said at the bottom, no live exhibits. And it brings to mind this notion that looked complicated. I think there are lots of patients in America that couldn't do those things. There are people who over the age of 60 who can't operate a cell phone beyond a simple dial. It depends a little bit on where you live. And so it seems you'd have a big challenge looking across the population at comparing, a farm community in Nebraska to a bunch of people in Cambridge, for example, and trying to make any sense out of it. So I don't know how you handle that, but that seems to be something we're thinking about.
Yeah, we're actually writing a lot about all of these issues, so I'll try to address them. So that's the major pushback, is like you find out that something is, turning into an angle that's worrisome. You're just frightening people. And doctors don't like that, because if they don't feel that they have a pill to prescribe, then they don't feel necessarily that they can be helpful in that situation. At the same time, the literature, I think, is pretty unequivocal about early detection being very helpful along many, many lines, including planning and including it actually decreases anxiety at the end of the day, and it helps with family support, et cetera, and it decreases the cost of care. Until we have a good kind of biological intervention that comes in the form of a pill. We're talking preclinical. So preclinical means you're not sick, or you can still work, or you can still do things. And this is not something that physician will do, but it will require the development of programmatic support for lifestyle change. The literature on neurogenesis is quite compelling at this point for exercise and intermittent fasting and longer periods of fasting. The nutritional support, but the problem is the problem with that is like the lifestyle changes are incredibly difficult. That's why the pill is so appealing, right? And that would require actually more psychologists, counselors, programmatic supports to achieve. But I think in the end, it's what we have, and I think it's much better than nothing. The other problem here, in contrast to bone density, you need longitudinal data to figure out what's a good marker. Now, if you get the pill tomorrow, we need now 30 years to figure out what's a good marker. It's like we're going to be playing decade-long catch-up on this. So I think we need to start now, and I'm hoping the pill will come along soon enough to at least get the attention of primary care, because we can't, right? But I think it's time to push on that. And you had a third. You had a third point there. Oh yeah, this is why I said that if you do deploy it in primary care, you will not be comparing. You'll be comparing apples to apples and oranges to oranges, because you will have the localized norms. If farmers in Nebraska will all be assessed. Now, there is a good question of whether they could do this, but we were able to show that even immigrants with 8 or 10 years of education has been able to do this. Computer facility is something that certainly the older people today have more of a problem with, but I think by the time this will be deployed, that question will be a moot point. So I think we still need to get out of the paper and pencil for posterity. There was some other question over there. Okay. Well, thank you very much.
Thank you, Boaz, and thank you all the audience for a very interesting discussion. I would like to introduce our second presenter today, Dr. Ron Hess. Ron is a founder and chief scientific officer of the Banyan Biomarker, a director at Banyan Laboratories in San Diego. I'd like to congratulate Ron for the first FDA approval for a first biomarker for the brain. That biomarker provide acute diagnosis of mild versus moderate traumatic brain injury, which I think the whole community that study traumatic brain injury was looking for it. Ron is working with interdisciplinary team to develop guidance for the use of blood biomarkers to improve the design of preclinical and clinical studies assessing the therapeutic efficacy of drugs to treat TBI. I think we're all aware of the challenges in that domain. Over the past several years, His interests have focused on development of biochemical biomarkers of acute CNS injury, including traumatic brain injury, detectable in blood. This research has been resulted in an ongoing clinical trial to secure the first FDA approval of biomarkers for diagnosis of traumatic brain injury in adults. So Dr. Hayes is going to present to us today the use of biochemical and imaging biomarker to improve the design of clinical trials of acute CNS injury, including traumatic brain injury.
Thank you. So a couple of side notes. First, when you talk about clinical trials in the brain, it's sort of like developing a plan for world peace. There's a certain amount of skepticism I think we'll all bring to this talk. That said, what I'd like to do is leave you with at least the willingness to entertain the fact that there are technologies and expertise available now to substantially improve the design and execution of clinical trials for not only brain injury, but brain disease. I know following on the failures of this week with the beta amyloid drugs, that's a haughty, maybe hyperbolic assertion. The second point I'd make is just a spontaneous comment to follow up on Boaz's, I thought, very excellent talk. These two talks in unplanned ways represent an intersection of biochemistry and function. And without an effective interface, progress in these areas won't be made. I don't know if I'll address that sufficiently. In fact, I probably, in the course of this talk, will be giving you more of a menu than a meal, but certainly you can, you're welcome to communicate with me. I've got a lot of people, other people on here, because I would not begin to claim competence in all the areas that would be necessary to refine our approach to clinical trials at TBI. So I have Dr. Alex Volotka, who just stepped down as president of the American Association of Neurological Surgeons. He's on the NINDS study section for clinical trials in brain injury. Actually chairs that session. Max Wintermark is a very well-known neuroradiologist with an interest in stroke and traumatic brain injury. Yours truly, a colleague of mine, Dr. Olena Glushakova, who is very deeply invested in some of the basic science that we do, as well as some of the reviews that I'll cite. And then I've concluded a biotech person just as an example of computer technology that I think may be useful in moving imaging forward. So, the problem, no successful clinical trials of traumatic brain injury. And even from 1980 to 2009, there were 33 failed trials, and this symposium, in fact, addressed just that problem, and there was a lot of head scratching, and life and failures go on. So we just recently finished a review, Dr. Glushakova, and in spite of that, and this is sort of interesting, there are a number of clinical trials, I don't know if you can see this, ongoing as of clinicaltrials.gov at around 2016 that were completed, terminated early, are still ongoing, using blood biomarkers for various diseases, including CTE, TBI, concussion. They're being used. It's not clear to me that they're being interpreted and incorporated effectively into the results of these trials. And the most obvious example of that, or examples of that, are the progesterone trials, which were conducted, one by NINDS, one by called Synapse. Progesterone was an NINDS study. Synapse was a pharma sponsored study. Both were negative. There were clinical samples drawn and biochemical analyses done of biomarkers in the progesterone trial that were never analyzed until we, systematically, until we are now undertaking that task. So the point I want to make is there are unused, if not squandered, resources that can be brought to bear. And we look forward to reporting maybe soon to ASENT or someone in the future on how these biomarkers potentially could have resulted in a reinterpretation of the clinical trial, similar to an example I'll give in a moment. So why have these clinical trials failed? Well, there are a lot of reasons, and there are a lot of reasons why there isn't world peace, but one reason is that TBI is not one disease. And I think most of us, and certainly even the field historically, has looked at traumatic brain injury as pretty much a unitary process. And I remember, I spent, fortunately or unfortunately, as a PhD, 20 years in neurosurgery departments. And I remember a crusty chairman, John Jane, talking about, he was chair of neurosurgery at University of Virginia, and John, in this inimitable way, said, I don't really know about traumatic brain injury. You can't fix a squashed cockroach. And with that graphic, if inelegant, dismissal, that represented the status of traumatic brain injury when I wandered into the field, naive from NIH, studying grander things, I thought. But let's think about this a little more deeply. So the Glasgow Coma Score, anytime you're admitted to an emergency care facility, somebody, probably a desperate little resident, will give you a GCS score, and it will range from 13 to 15, and you're pretty normal. 8 to 12, you're goofy, but arousable, and then less than 8, you're pretty comatose. The scale has existed for 45 years. It was never intended to be an acute diagnostic scale, and it still persists today. And so it becomes, diabetes is called diabetes because in 16th century medical diagnostic lexica, flow through. I mean, it was a descriptive diagnosis, excessive urination and water intake. And in a way, traumatic brain injury today remains a descriptive diagnostic category. Even like Caesar divided Gaul and God into, not Caesar, of course, but, and God is divided into a trinity, traumatic brain injury is divided into mild, moderate, and severe, which I think represents more the human prejudice for trinities than for any kind of intellectual rigor. And those terminologies are invoked today. Consider that. So we know, this is a slide first assembled by colleagues of Jeff Manley's and used quite often, and I appropriate quite shamelessly, is just CT scans of different kinds of traumatic brain injury, an extradural hematoma, a contusion hematoma, diffuse injury and swelling. Here, excessive swelling, the ventricles are compressed, subarachnoid hemorrhage, subdural hematomas. All of these are different neurosurgical entities, and yet all are included in treatment cohorts indiscriminately. And they were in the most recently failed trials in spite of, well, let me continue on my rant. Traumatic brain injury, unlike cancer, as I said, it is diagnosed simply descriptively. And cancer, as we know, is a modern disease classification that is a mixture of anatomical, physiological, metabolically, and immunologically and genetically defined diseases. So you get a very refined current diagnosis of cancer and treatments that at least putatively are supposed to target that specific diagnosis. So one solution then is to stratify clinical trials by subtype of TBI. And my argument today is that blood biomarkers and imaging can help. And let me turn now to the argument of why classification is so important. One of the more prominent, actually I did the preclinical work that underlay the feasibility of this study, which argued the NAVIS trial, which argued that moderate hypothermia would be an effective treatment for severe traumatic brain injury. And the trial, as we know, failed. It failed for a number of reasons, including there was more variability in the drug between centers than within groups. And we can discuss that after the talk if you wish. But then a post-HOC analysis was done of a special cohort of evacuated intracranial hematomas. And in that post-HOC analysis, the trial was effective. So there was a subset of patients for whom the trial, if cooling was done sufficiently quickly, had only a 41% mortality, poor outcomes, versus a 62% for those who weren't cooled or cooled in time. So we knew this, but the wheel keeps turning. So biomarkers. Most of us know what biomarkers are. I just wanted to emphasize that they don't have to be blood biomarkers. They could be any internal indicator of changes in organisms at a molecular level or a biochemical level. It provides information ideally about injury mechanisms or processes. And until we got our FDA approval, there was no blood test for the brain. There was a blood test for every other organ but the brain until we succeeded. The FDA, to its credit, is moving towards a common regulatory lexicon. And the use of biomarkers that I would focus on today are to use biomarkers to distinguish between patients who have a TBI or not. And even within patients that have a severity, a range of diagnostic subsets. And then to predict biomarkers that provide information on the likely course of a disease, how the particular patient will fare in the absence of a therapeutic intervention. Outcome prediction is for clinical trial design with, say, rolling dichotomies and various futility analyses, is not just an important clinical tool to inform the patient and the family. It's an important biostatistical tool around which you can design the expected outcome in treated versus untreated patients. They're predictive biomarkers for the patient to respond. Ideally, we'd like to be able to predict. We're working in a trial that's very close to my heart. It's to deal with perinatal brain injury, for which there is a therapy, moderate hypothermia, but only 1 in 8 neonates respond. And we'd like to know, it's a very onerous trial, we'd like to be able to tell which patients, which neonates will respond and won't, and we're moving towards that. Response biomarkers are show that how a biological response has occurred, and that could be, and I won't talk about this, but we have a lot of information on our biomarkers providing data on neurotoxicity, period. Neurotox is assessed now very crudely, preclinically and clinically, only by behavior or histology, both of which have their own problems. But we think we can supplant that. Target engagement and, you know, the holy grail of a surrogate marker. So what can blood biomarkers do? And I want to certainly not over-represent blood biomarkers, but I do want to inform you of the potential. When I'm sometimes asked, you know, by people who want to start a company, there aren't many people who have the blindness or the absence of frontal lobes to start a company in brain injury, but I tell people you really have to be informed by your naivete, because if you knew what you were doing when you started this, you probably would, you know, look at TV or something. But I thought I'll discover a biomarker and, you know, the world will be better. But in fact, it's a very complex and rich field. And it's easy, someone said earlier today, it's easy to say discover a biomarker. The real work is the clinical validation, to do the scientific groundwork that allows you to bring scientific and clinical meaning to the biomarker. So it becomes important to choose biomarkers that can inform you not only about injury, but the specific subcellular localization of injury and potentially the injury process. For instance, these two biomarkers, this can inform you about necrotic cell death and activation of caspase-3. This can inform you, apoptotic cell death. This can inform you about necrotic cell death and calpain activation. You can get a lot of information about subcellular localization. I won't go into this, but it's important to bring a thoughtful understanding of the pathobiology of the disease or the injury and the mechanism of drug before you pursue this. Another often overlooked issue is the biokinetics of biomarkers and how they can provide a window, a diagnostic window or a therapeutic window. For example, if you're treating a very acute changes, then you're going to want to look at a different family of biomarkers that are than you would where you're looking at chronic changes that are often more related to inflammation. So UCHL1, for example, is a marker of evanescent brain injury, the transient first secondary cascade, probably related to depolarization and activation of proteases. The more sustained changes are probably devoted to delayed microvascular compromise and increased interstitial inflammation. We've published all these areas, and I can give you the data. I will, as a sidebar, say that the role of the blood-brain barrier in biomarker availability is grossly misunderstood, misrepresented, and in many cases represents a straw man. It was an impediment to the early arguments I made about having access to markers of brain injury in the blood. But if you want to talk about that later, we can discuss that further as well. So, as Sharon mentioned, we did get FDA approval. That's the good news. The bad news is it's really for quite a limited indication, as the FDA does. It's simply to discriminate between mild and between moderate and severe TBI, or rather mild and moderate severe TBI, is defined by the presence or absence of lesions detectable on CT. So with this test, you can determine whether the patient is at risk for a brain lesion and mandate a CT scan and eliminate unnecessary CTs. It is a cost-effective indication, and it has a lot of appeal in emergency rooms, but it's, as I would be the first to admit, quite constrained. It was driven in many ways by the FDA, who does not, is still having challenges recognizing the kinds of measures that I think are so critical that we talked about earlier, Boaz talked about in his presentation. The need for the reliability of the kind of markers that you are developing is critical. And it's impossible to make progress without a joint effort in these two areas, I would add. So, but the FDA, in its, who's it, Greenspan, its exuberance, they were very happy about this approval. It was approved in an accelerated pathway that was mentioned earlier, but they referred to it as an evaluation of concussion. It is not. They didn't approve it for that, but their press release mentioned it in a headline, and we've been trying to clarify that. There is not a blood biomarker for concussion, and we can talk about that at the break if you wish. But they are, you know, the FDA has already written a letter of support to the use of a UCHL1 and GFAP in clinical trial execution and design. This was written to the TRACK TBI team led by Jeff Manley, in which our company has collaborated with TRACK TBI. And the FDA's view of it is to use it in cohort enrichment, especially in mild TBI, where you know, how do you define it? That's its own problem in and of itself. And if you have cohorts of patients that are identified on the basis of biochemical changes, that might enrich the possibility of seeing effects within that group of patients. So, I mean, why do we think the biomarkers can do this? And now I'm going to do the kind of thing I don't like to do in a talk, and that is just kind of step through some slides to reassure you that there's a rich peer-reviewed literature that I'm happy to provide on the points that I want to make. And I think they're probably not, and most of this literature was not generated by me. Some of it was, of course, maybe a lot of it, but a lot of it wasn't, and it's by independent investigators, notably TRACK TBI and others. And the point is that biomarkers in severe traumatic brain injury have been shown repeatedly to be reliable predictors of outcome in severe TBI patients and injury magnitude. And they're also being used now aggressively in preclinical studies. And so the preclinical studies, which I participated in with a colleague of mine led by Pat Kohanek, is Operation Brain Trauma Therapy. And its goal is to organize a coherent preclinical model of therapy screening that would interface directly. So you begin your clinical trial design and your preclinical testing explicitly. You use blood biomarkers, and you look at 3 different models to see if you can identify maybe different injury phenotypes, mild TBI versus contusion versus penetrating. And I'm not going to go, the group has, I'm not going to go into the details of the algorithms or the rigor with which this work was conducted, but the group has successfully identified 2 promising candidates, glavuride and Keppra, and in this group, the biomarker GFAP primarily was associated with therapeutic efficacy. And if that's the case, then you have a seamless transition from rodent to human for biomarkers as a measure, if not as a primary outcome measure, certainly as an ancillary measure, and even in phase 1 for safety, which I would think these markers could function. So the group thought that because glavuride was primarily effective in a model of focal contusion, that would be the cohort on which the drug would be tested in severe TBI. But in the clinical data, there are a number of papers, I put them here and I can send them to you, that show that the biomarker levels, in this case GFAP, increases in elevation with a magnitude of injury. This is shortly after, these are all acute, shortly after injury, generally within 12 hours. And even in mild TBI versus more severe TBI, we can see it. In severe TBI, we have at least, for severe TBI, we have a good indication of the biokinetics of the markers, where GFAP is more sustained, and UCHL1 and other markers are more evanescent. So we know a good deal about these markers. Here for the SBDPs are these markers of proteolytic activation, by the way, and they're related to injury magnitude as well as UCHL1. I'll linger a minute over this slide because in many cases, for instance, in an intensive care unit or a severe brain injury patient, you don't have any information about what's going on in the brain, no direct information. The only way you get it is to take the patient out and do a CT, which is usually resisted for appropriate reasons by critical care medicine physicians. So it would be helpful if you knew, even from blood biomarkers, not only whether the patient's brain was getting better or worse, but whether the patient was showing a profile of diffuse brain injury or focal brain injury. And these markers, it turns out, the reasons, there are two assumptions to the interpretation of these data. Glia are more robust than neurons to biochemical insults. That's been well documented in a lot of the ischemic literature, shows that. And there are 10 times more glia than neurons. So under those two assumptions, if you excise a bunch of tissue in a contusion, you're going to whack more glia than neurons. On the other hand, if you have a biochemical insult, you're going to kill more neurons than glia. So diffuse injury, UCHL1 levels would predominate, and focal injury, GFAP would predominate, and it turns out the ratios of those two reflect the CT profiles from the patients from which they're drawn. So without getting a CT, you can get some information that might otherwise be extracted from a CT. Improving outcome. Now, since the 80s, there was a big effort in the COMA data bank to improve outcome prediction, and a big, clunky, but very powerful impact outcome calculator was generated. It's not clinically practical, but it does a great job in research. And we've shown that our biomarkers add predictive power to the outcome over every other variable that had been used to predict TBI outcome. And then finally, getting back to severe TBI trials, and this is a particular area of interest of mine now. Was it 5 million patients, 5 million Alzheimer's disease patients? There are almost that many patients admitted to ICUs annually in the United States. Every patient, every critically ill patient admitted to a neuro ICU is at risk for a secondary occult brain injury. It's most apparent in critical illnesses like sepsis. But certainly, we just finished a paper that'll be coming out soon with pediatric critical care work at the University of Pittsburgh showing a relationship between the biomarkers and the occurrence of occult brain injury and poor outcome in pediatric critically ill patients. The reason for, the reason for that most probably is that And I can send you a recent JAMA vision piece to that point by David Menon and John Hasker at, Menon's at Cambridge, Hasker's at Mass General, arguing that the current practice of clinical care medicine is flawed by the artificial division of managing systemic versus CNS integrity, and that they need to be done conjointly. You can't do that unless you have ongoing concurrent assessments of brain injury. There are a lot of candidates for that. Blood biomarkers are some of the more obvious, and we're involved in those studies, as are others. And that's where that and perinatal brain injury are kind of my big current things, or two of them. So this is I'd encourage you to look at this paper, but what this paper simply points out is if you were to look at brain biomarkers, and a lot of people have, it's an excellent review. This is a very talented young critical care physician now at Cambridge, Eric Thalen. And what he's arguing is that in a normal situation, you got brain injury and it'll resolve, but there could be, if the brain injury continues for a variety of reasons, the biomarker levels will be more or less sustained. And if you have a secondary insult, say the patient becomes hypotensive or intracranial pressure elevates to compromise cerebral blood flow, you'll get a secondary spike. And if you know those, you have, for the first time, a handle on the real clinical course of the patient. Sepsis is classically defined as a multi-organ injury. It can result in multi-organ damage. And to say the brain isn't a part of that repertoire seems inappropriate. So, to imaging, I'm not an imaging person. I've been fortunate to be mentored by Max Wintermark at Stanford, who recently published a scale that we have scales already for to look at imaging and classify it. The Rotterdam scale and the Marshall score, a variety to look at how different profiles of traumatic brain injury detected on CT. This scale is quite different, and it informs the patient, the consequences that you could expect for the patient, and what kind of intervention is going to be needed. And you go from 0 up to 4, where there's a high probability of death. And of note are the patients, I think in 1 and 2 that follow up neuroimaging or admit for observation or admit for more advanced care unit. These are the patients, in my mind, that would probably be amenable to treatment. The patients that are going to get surgery are probably going to be a pretty messy group to do a study on, but we can talk about that more as well. And Max has gone into a variety of ways to classify this, but nearest one, for example, nearest 0, it's been validated. He's validating it with us. He's doing post-hoc validation in a variety of cohorts, including the biomarkers. So we'll be looking at the ability of the blood biomarkers to enhance the predictive accuracy of the nearest scale, which seems to perform quite well. So in closing, most CTs are read by neuroradiologists, and of course neuroradiologists do a great job, but a neuroradiologist's report is not quantitative, and while you have the DICOM files, it'd be very nice to have quantification. There are, this company, which I'm working with, by the way, I'm conflicted with Banyan. I didn't know if and I'm not with Icometrics, but I like the company. But it provides an opportunity to do quantitative, real-time CT scoring, including volumetric analyses. And if you're going to really start looking at CT as a discriminator, you want more than a neuroradiologist read. And you want it in real time, and you don't want to have it arbitrated. So I highly recommend this as a technology. to go forward. And so that's it. And I thank everyone for their time and attention, or at least alleged attention, and I'm available for questions.
Is this on? Are your biomarkers a part of the large NCAA Department of Defense concussion study that's ongoing?
Yes, they are.
Great.
So they aren't the only biomarkers. Those studies are, there are two separate studies, one led by Mike McCrae and Kevin Guskowitz, and the other by a psychiatrist, blocking on his name. Yes, Tom McAllister. Thank you. See, senility. What are you going to do? And they will have some publications coming on that. There's another young guy, Brett Naskew, who worked with that, who just had a JAMA opinion piece come out. I commend to you about biomarkers for sport concussion and how they are probably best understood almost in a brain health model. The issue with sport concussion is the same as with mild TB and the same issue that Boaz is dealing with. How do you deal with these subtle, almost preclinical changes? And then how do you link those to biochemical events? And it's almost, and he actually talks about the challenges. I should have put this in my talk, just look it up. Brian, ASKEN, JAMA came out a month ago. It just came out. He relates it to the challenges that face Alzheimer's disease. I guess you have my contact information. If anybody emails me, I will be a good soldier and email it. I was really impressed by it. I called him up. I thought it was just great. But the point I'm making is that linking the biochemical and the cognitive is a huge challenge. And I think it's going to be addressed in many ways, just as Boaz discussed it. It's a brain health issue, and it's going to have to be looked at. It won't be a simple hip bone connects to the thigh bone biochemical and functional relationship. It's a much deeper and more complex issue than that. And unless we recognize the emperor's nudity, we're not going to be able to dress him. Yeah.
I have a quick question. Is there any convergence between the biochemical markers that you're describing now and any markers in psychological brain injury as opposed to traumatic brain injury?
That's a wonderful question. And it goes, and I again commend this opinion piece, but I, as an ex-military person, am interested in PTSD, and we're involved in looking for markers of PTSD. I'm not optimistic. I'll be the first to admit it. And I'm not sure that depression, I'm not a psychiatrist, and so I have to defer to the psychiatrists on this, but that's going to be a very tough one. And the social variables that influence it are significant. The rates of PTSD among U.S. troops are much higher than they are among British troops or other countries. I don't know why, but there are a lot of social factors that are clearly influencing it. But it's definitely worthy of study. Sorry, I can't give you a more focused answer.
Thank you.
Yes.
I was wondering if you could speak for a minute about the payer response to your TBI test.
Yeah, we're getting a code. CMS we'll get a code for it. We'll start distributing it next year. I'm not a medico-economics person, and nor am I'm not interested in it. I like making I like having money, I don't like working for it, so it's not a motivator for me, but we're getting paid. I don't know how much yet. Sorry to be so cavalier, but I'm being honest. Yeah.
I was wondering if you could comment on, I guess to me it seems kind of obvious that you should be splitting the TBI categories apart. Can you comment on why people didn't do that? Was it just pure numbers or something else?
That goes to an interesting discussion that Boaz and I were just having before about the nature of science and the philosophy of science. And science is a very human and very social enterprise. And zeitgeist is real. So the key opinion leaders determine directions that science takes, often driven by all of the scurrilous and mean motives that drive us all, money and ego. And I just scanned a book Boaz gave me on the metabolic theory of cancer that was discarded, written off back in the 70s, but originated far earlier. I mean, it's not a subject of wide study, but for reasons that are sociological rather than scientific. And if we only look at global warming and how that is viewed today, we'll see the answer to that.
Great, thank you.
Okay, thank you.
I would like to thank both of our speakers today. I greatly enjoyed in person to listen to the talks. I hope same goes for you. And thank the audience for wonderful questions. And I invite you for an extended coffee break outside.